Sorry, could you see my screen?
Yeah, it's okay. We can see it, yes.
So the first session was about the unobstructed coronary arteries. And this session is going to be about the acute myocardial infarction and obstructed coronary arteries. Before going inside these sessions and the lecture, the slides, I think that I need to give like a brief introduction about what happens in the acute myocardial infarction and ischemia in order to see what is the role of MRI in acute coronary syndromes and acute myocardial infarction. As you may all know, that what happens is when obstruction and reduced coronary arterial supply, then there is imbalance between the supply and demand. And when occlusion exists or take place, then ischemia arise. And if this ischemia, this area at risk, continues more than 40 minutes or more than 1 hour, then a wave of necrosis and the myocardial infarction will start. As you may see on this slide, MRI is not playing any role. So if the patient is experiencing STEMI, then this means or equals to immediate PCI. And if it's non-STEMI, it's early PCI, so within 1 or 2 days, maybe plus minus some non-invasive diagnostics. For example, stress echo, labs, and maybe ACG. Intermediate low risks, those are the patients that we see in CTs, especially if they are young patients. And MRI is not in this imaging guidelines so far. But in order to understand the role of the MRI, we need to know some of the factors that will affect the outcome of any reperfusion or any PCI. The initial size of the myocardial ischemia, whether it's a large territory or a small territory, the existing function before the attack. One of the main or one of the important factors is the time for the reperfusion, because this time is the time where the wave of the myocardial infarction will terminate and the area of risk that will undergo necrosis will stop. Patients who have preconditions, diabetes, hypertension, have the worst prognosis. We have published a paper comparing different sequences of edema and in acute myocardial infarctions. Patients with diabetes and hypertension showed the largest infarct size, the worst LV functions. Collaterals is a very important factor, because if there is a good bed of collaterals, probably the myocardial infarction will be small and will be less liable to have reperfusion injuries and MVOs and hemorrhage. The TIMI flow before the PCI is also important, whether it's a total occlusion or subtotal occlusion. Any distal emboli took place during the PCI is also a very important factor. Reperfusion injuries, if the ischemia continues more than 3 hours, and then PCI, reperfusion, some mediators will be released, and those mediators sometimes cause the disruption of the cell membranes, which will lead to MVO and hemorrhage, although that the patient received the PCI and reperfusion. Sometimes the capillary bed is now showing dysfunction, and those patient gets an MVO and hemorrhage. So what are the goals of any PCI? The first goal is to stop the wave of the myocardial infarction, to decrease the area that is at risk. And the main goal of a primary PCI is to prevent any adverse effect or any adverse remodeling that might take place to the left ventricle. So protecting the myocardial, or to stop the myocardial infarction wave, is to minimize any remodeling that might happen after the heart attack. And this is the main goal of any PCI. And adverse events are defined as being change in size, mass, the geometry and the sphericity of the left ventricle. And those events are the protecting the patient from those events is the thing that will protect the patient from having ischemic heart failure or readmission, or affects the morbidity and the mortality risk in the next 5 years after the myocardial infarction. Understanding this, that the goal of the PCI is to prevent and stop any adverse events or any remodeling, negative remodeling of the left ventricle, then we would understand that the role of MRI would appear in the post-MI when the MI stabilizes, so during day 2 until day 7, because most of the domains that you see on the screen now could be easily assessed on MRI. So MRI could easily assess the wall motion abnormalities, the functions, the volumes. MRI could measure the area at risk, the salvage area, infarction size, MVO, hemorrhage, or edema. So the main role of MRI is after the myocardial infarction and in the risk stratification of those patients. So those are the main points that I'm going to discuss in the next slides in order to see how important are they in evaluating those patients after having the heart attack. For example, the CNI imaging. So the CNI imaging providing the ejection fraction, end diastolic and systolic volumes, the shape of the left ventricle. As you may see, or previously, it was thought that any increase of the left ventricular end diastolic volume or the left ventricular stroke systolic volume by 15% or by 20% indicates a very bad prognosis and a high mortality rate. Recently now, this percent has been reduced down to 12%. So measuring the volume, end diastolic and end systolic volume is crucial for those patients. And during the follow-up after 6 months, any increase of 12% in the left ventricular stroke, end diastolic and systolic volume would indicate a negative remodeling, which indicate a bad prognosis for this patient. Negative remodeling considered as 12%. So if there is no increase, or if there is on the other side, if there is a decrease of 12% in the end diastolic or end systolic, this would be considered as positive remodeling. So the other direction. And if there is no, and everything is stable, it's that there is no reverse remodeling or it's zero remodeling. So it's really important to comment on the end diastolic and end systolic, because in the follow-up, this will tell the prognosis of those patients. Recently, there are many softwares now have been introduced in the market. So Echo could measure the longitudinal, MRI is used to measure the radial function.
Dr. Ahmed.
Yes.
Follow-up MRI is done after how long?
So usually 6 months is when you start seeing the remodeling effect. So usually 6 months to 1 year.
Thank you.
Yeah. The edema, usually most of the literature is seeing that the edema would be resolving and the MVO within 3 to 6 months. That's why it's recommended to do the follow-up 6 months to 1 year, to give a chance, an opportunity that that the edema and the MVO areas would be wearing off. MRI is used to measure the radial function, but now in the market now there are many softwares now introducing the longitudinal and the circumferential functions and the strain rate in MRI, and the literature showed that the circumferential function and the longitudinal function are also correlating significantly with the main